Okay, this is our lecture for eyes and ears. I believe this is chapter 21 in your book. So we're going to go over this section as the last part of our discussion for these chapters. So we're going to skip our objectives. So when we talk about the ears, we want to identify conditions that may cause any conductive and or sensory neurohearing loss. We want to list and describe ways to do hearing testing. We're going to get to all that. So let's talk about key terms. These key terms are going to be important for you to know. Okay. We want to talk about visual acuity. So visual acuity, that is the sharpness of our vision, how well we see. Refraction has to do with bending of light rays that come into our eye, and that just helps the focus on the retina. Errors in refraction are the most common causes of our visual defects and our visual acuity. So the reasons for these things, right? Color blindness, that's the inability to distinguish colors. A congenital defect is inherited or present at birth. An acquired defect is something that develops after birth or over time. Irrigation, that's when you wash a body canal with a flowing solution. And installation is dropping a liquid into a body cavity. So we're going to start with visual acuity. So visual acuity, that's the ability to see clearly. So a person who has good or has normal visual acuity has the ability to see clearly and has the ability to distinguish fine details both close up and at a distance. That means that you have 20/20 vision if you have normal visual acuity. This 20/20 vision, this normal visual acuity, also means when we talk about 20/20 vision, it means a patient can see clearly at 20 feet what should normally be seen at that distance. It doesn't necessarily mean that you have perfect vision, but it means that at 20 feet you can see what the normal average person can see. So if you have 20/100 vision, that would mean that you can see clearly at 20 feet in as opposed to someone who has normal vision, they would be able to see that at 100 feet. Let me try that again. If you have 20/100 vision, you are going to have to stand 20 feet away from something to see it well, as opposed to someone who had 20/20 vision, they would have to stand at 100 feet to see that well. So they have better vision than you. I hope that makes sense. When we talk about errors of refraction, the first error of refraction we're going to talk about is myopia. That is when the eyeball is elongated, so it's long from front to back, and this is what we focus on as nearsightedness. So it's always the opposite. So our difficulty if we're nearsighted is that we can't see things far away. And what happens to that is the light rays that are brought to focus in on the retina, that happens just in front of the retina, so it doesn't reach it correctly. So people who have myopia or nearsightedness, they might have a lot of squinting, they might experience headaches, and the way to correct that is through contact lenses. Or some type of, like whether it's eyeglasses or contacts, whichever, but it allows light rays to focus on the area of the retina that it should. Again, if we remember what refraction is, it's that bending of the light rays so that it can focus on the retina. And on this myopia, the light rays focus just in front of the retina. So basically, when we have an error of refraction, there's a defect in our eyeball. Hyperopia, that's when the eyeball is too short from front to back. So this is also known as farsightedness, where you can't see things at a reading distance or a close working distance. So the light rays hit just behind the retina, And usually you'll have blurry vision, headaches, and you're straining your eyes to see things that are close up or at that working distance. Again, you can use corrective lenses to repair this so that the light focuses on the area of the retina to help you see better. Another area of refraction is astigmatism. That's when the cornea of the eye, so this isn't so much the retina, but the cornea is the oval-shaped part of the eye, and it affects, so the light rays that are coming in to the retina, they're focused at two different points because of that oval-shaped cornea. The cornea should normally be very round and smooth, so it's irregular in some way. It often occurs with the myopia and the hyperopia, so with nearsightedness and farsightedness. Usually lenses will correct this as well. Presbyopia, this is the decrease in the elasticity in the lens of the eye. This is the aging eye condition, or the time in our lives when we need bifocals. It usually begins after 40, and when you have visual difficulty, it's a decreased ability to focus clearly on objects that are close up. So usually people need bifocals or some type of reading glass to help with this, reading glasses rather. Bifocals are just different in the bottom portion of the lens, so when you look down, you can see things well. And all of those, the myopia, the hyperopia, the astigmatism, and the presbyopia, those are going to be important for you to know. Okay. Assessment of our visual acuity. So this is how we test, how we diagnose distance, trouble with distance and near vision. So this is how we use to diagnose these. There's a distance visual acuity and the near vision acuity. So the charts used that we test for distance are, the common one is this bottom bullet point, which is the Snellen chart. It's letters that are in decreasing size, and it usually starts with a capital letter E, and it decreases the size of the letter in various, these are the different types of charts used. So there's letters in decreasing sizes. The capital E can be used in different sizes, and it's pointing in various directions. That's another type of test that's used, or pictures of objects. And the Snellen chart is the most common one. Usually we use those letters in decreasing sizes for our school-age kids and adults. And that letter E can be used like for preschoolers or people who don't speak English, maybe someone who's illiterate. Pictures of familiar objects, you might use that in preschool age, but you want to make sure that they know what the objects are that they're looking at. And again, that Snellen chart is the most common form of testing that we use. This is what you'll use. Well, you could use all of them, but the Snellen eye chart was developed by Hermann Snellen in the 1860s, and it's, again, the most commonly used. It usually consists of 11 rows of capital letters. You can see that here on the right side of your screen. So the first row is one very large letter, just a single letter, and then each row has an increasing number of letters, and they decrease in size as you move through the chart. So you want to make sure that you're doing this in a well-lit room. There's not many distractions. You want to perform it at the distance of 20 feet. So you want your patient to be 20 feet away from the chart. Usually a good place to do that is in the hallway of the office. So if a patient wears prescription glasses or contact lenses, they want to leave those in their eyes or their glasses on. And you measure each eye separately. And it's important to use an eye occluder so you're not using their hand and they can't cheat. If they wear reading glasses, you're going to want to have them take that off, and you're going to want to document if the test was performed with their glasses or their contacts in. You want to make sure that they keep the opposite eye open when they're putting the occluder over the eye that's not being tested. and that you want to disinfect that occluder after you're done using it. So when you interpret the Snellen chart, the smallest row that can be read accurately indicates the visual acuity in that eye. So there's two numbers next to each row of letters. So the number above the line is the distance at which the test was conducted, so 20 feet, and then the number below the line is the distance from which a person with normal visual acuity can read the row of letters. So what does it mean if a patient has a DVA of 20/30? So it means that the smallest line they read at 20 feet, they would read at 30 feet. 20/20, that's a normal. 20/20, that is what you want your vision to be. That's the normal distance visual acuity. That's what it means to have good vision, if your vision is 20/20. If you are at, now I just lost my spot. So if you are that 20/30 person, it just means that you are reading at 20 feet what someone with 20/20 vision could read at 30 feet. It's not necessarily a bad thing to be 20/30. If you're 20/15, that means that you can read at 15 feet what someone with 20/20 vision can read at 20 feet. So actually, you are above average in your vision. So the smallest line you could read at 20 feet was at the row 15. 20/200, that means that's the acuity of someone who is considered to be legally blind. If we look at the Big E Snellen chart, this is used to test visual acuity, the distance visual acuity in preschoolers. So you might have to take some time to explain this to a child. You might have to draw an E on an index card and then teach the child to point that E in whichever direction they see it by turning that card in different directions. Their parent might need to help them. They might need to help them hold the occluder. It's more of where you might have to play a game with them. Maybe you're going to play a pointing game. You want to make sure that you don't force them and that you're giving them some time to practice. And then you interpret that the same way you would as a Snellen chart. If you can see these little lines, this says 20/35, I think. I don't have very good vision either. But you can see these numbers on the side, which if they read this line, that's what their vision is. And it's interpreted the same way. You might want to give them like a sticker or something if they can do the test well. So then we test near visual acuity, and this is, again, we're testing the ability to read objects up close. There's different kinds of cards that you can use to do this test. Again, you want to perform it in a well-lit room. You want to hold the card at a distance of 14 to 16 inches away from the patient. If they wear reading glasses, you're going to want to have the patient wear those as well. And then you're going to test each eye separately again. So all of these tests, you're going to test each eye separately. Again, the eye occluder over the eye not being tested, and you want them to keep both of their eyes open. And then the patient's going to read one line or one paragraph until they reach the smallest line that can be read. And you're going to want to assess for any unusual symptoms. These cards can be different size of type, like from the size of a newspaper heading, and it can go all the way down to just very small print. It might be paragraphs, words, or pictures. It just depends on the cards. The symptoms that you might want to watch for are like squinting or tilting of the head, watering of the eyes. That might just tell you that they're having some difficulty reading or completing the test. Again, you record the results as the smallest type the patient could read with each eye. and then the recording based on the type of test used. So you want to make sure you're, putting in what test what cards you used, what their vision was in each eye, and then any additional documentation, like those unusual symptoms that they might have had, like the squinting or tilting of the head. So if we talk about eye specialists, there's three kinds. There's an ophthalmologist, an optometrist, and an optician. So the ophthalmologist is someone who specializes in the diagnosis and treatment of diseases and disorders of the eyes. They can prescribe both ophthalmic and systemic medications. So ophthalmic medications are just specific for the eye, and then systemic medications might be a medication you take by mouth to treat an illness or a condition. Maybe they get eye injections. So that would be specific to an ophthalmologist. They would also, like I said, they would do, I don't know if I said this, they would do surgical intervention so they could perform a cataract surgery. An optometrist is someone who has expertise in measuring visual acuity and prescribing corrective lenses. They don't typically prescribe medications, and they don't typically do surgery. They might be able to tell someone that they have a cataract and refer them to an ophthalmologist, but they cannot do the surgery themselves. An optician is someone who interprets and fills prescriptions for glasses and contacts. So they're more responsible for the design, the fit, and dispensing the lenses. So that's someone like you or I, we could go and be an optician after we've had some training and work maybe in an eye doctor office to help patients get their glasses and contacts. So if we look at color vision, deficits of color vision are classified as either congenital or acquired, and we talked about congenital and acquired. So congenital is something you're born with. Acquired is something that happens after birth. A lot of times, if they're, we said inherited, they can be at birth, or congenital is inherited and is present at birth. Acquired, it can be from maybe they've had an eye injury or a brain injury or a disease, maybe a medication that's affected their eye. A color vision test can detect congenital color vision deficits, and it can be performed in the office. It's a basic color vision screening where you might, if you're just doing basic, on that Snellen chart, there is a single red line and a single green line. That would just be a basic color vision screening that you might do when you're performing that Snellen test. The more in-depth is the Ishihara test, and we'll talk about that. The Ishihara test is a book, and it contains a series of plates that form a number against a background consisting of contrasting colored dots. If you look in your book on page 446, there's a picture of two plates from the Ishihara test. So each page has a single plate. There might be green dots, like different shades of green, and there might be a number in yellow dots that they have to identify that number within that plate. So this can detect both congenital color blindness as well as red and green color blindness. I think that red and green is the most common, or it's blue and gray, I can't remember. But there's 14 color plates total in this test. So normal color vision, the patient can read the appropriate number within that plate. You can use plates with color winding lines for patients who are unable to identify numbers by name. So you might have them use like a pencil or like an eraser on a pencil to trace the number that's within there, so you know they can see the difference in the color, maybe if they're preschool, or if they can't, they're not English speaking, maybe they can't read. You could always try that. Again, natural daylight in a quiet room, they could use a cotton-tipped applicator. instead of their finger to trace the lines. That can kind of wear the coloring that you don't want to do, because that color is, of course, important. When you look at that first plate in the Ishihara test, anybody can see that. So there's no color blindness that's tested on that, but everybody can see it, just so they get an idea of what they're supposed to do during the test. Again, they can trace the line of the number or the different colored dots with a cotton swab or a pencil eraser. So normal color vision, you can see 10 or more plates. If there's a deficiency, there's 7 or fewer read correctly. And usually the patient needs referred to an ophthalmologist or an optometrist to talk about their color vision results. The only time I've ever done this is whenever I've done some work physicals, and that was more like in an occupational health department. That was part of someone who was going to be taking a new job. They would come in for a new hire physical, and part of that physical was doing the color testing, and it was for people who worked in factories, and they were doing some packaging, so it was important for them to be able to see the correct colors. Otherwise, the Snellen chart, if we talk about that a little bit more, you will use that Snellen chart a lot during physicals. So truck drivers or like a lot of farmers will get what's called a DOT physical, Department of Transportation physical, and it gives them their CDL license so they can drive those big trucks and semis. A lot of times those patients will get a eye or a vision test. Kids going to school, so for school physicals and sports physicals, that is a lot of times when you will do that Snellen test as well. So you will do some of that. Eye irrigation, you might see some of this, but this is the tube that you would use. That rounded part at the bottom is what goes over the eye. So when you're irrigating the eye, you're washing the eye with a flowing solution. So this is an important step if someone has a chemical injury. So if they're exposed to a chemical in the office, then they would get the part of the tube, this part of the tube would be connected to like maybe some saline, and then this part goes over the eye, and then the fluid comes through the tubing here, and it helps flush the eye. So again, you can do it when there's an ocular discharge from the eye, or I don't know how to get that to go away. You can do that when there's a discharge from the eye, or if it comes into contact with, again, harmful chemicals. Okay, there you go. You, of course, want to make sure you explain the procedures to the patient, and I believe this is a Morgan lens. I think that's what that's called. So if you're going to do an eye installation, that is when you put a liquid into the lower conjunctival sac. So you're going to put it in the bottom part. You would pull their eye down, the skin of the eye, and you would put it right in that bottom part of your eye. You can see, it looks kind of funny. But that's where you would, in that lower conjunctival sac, right in the bottom part of the eye, that's where you would want to put any kind of medication like an antibiotic eye drop or like a lubricant, any kind of drop that would use to dilate the pupil or maybe anesthetize the eye, make it numb. Medications that go in the eye can be liquid or ointment, and you just want to make sure that whenever you are putting in eye drops, you don't want to let the tip of that medicine come into contact with the eye. My favorite place is to put it more in the corner of the eye and have the patient look up, and then you can drip that just right into the lower part of their eye, and it seems to be more comfortable. Again, you would use that those eye drops maybe to treat like pink eye or conjunctivitis. When an eye is dilated, sometimes that will happen at the eye doctor, so they can look back and see the patient's retina or the back of the eye. Hearing acuity. So this is the part of the complete physical exam. Patients who have hearing loss may not be aware that they do, and usually it's a family member that recognizes before the patient. Normal hearing, so the normal the frequencies of normal speech range from 300 to 400 hertz per cycle per second, or hertz per second, or cycles per second. I would maybe make a note of that just to kind of remember that. If someone does have hearing loss, they might be referred to an otolaryngologist, an audiologist, also like an ear, nose, and throat doctor. Early detection and treatment can help prevent hearing loss. There's three types. There's conductive, there's sensory neuro, and mixed. Conductive hearing loss. That results when there's a physical interference with the normal conduction of sound waves, and that's through the external and the middle ear. So the amount of sound that is reaching the inner ear is less than what it should be. Usually it's detected during exam with an otoscope. An otoscope is that little device that the doctor uses to look into your ears. Conductive loss in the external ear is usually caused by an obstruction, like impacted cerumen. Cerumen is earwax. Otitis externa, or external otitis, is more when the outside of the ear is painful. That's commonly known as swimmer's ear. Foreign bodies, kids like to stick things. There can also be benign growths or polyps that can attribute to hearing loss. If the loss is in the middle ear, so external ear is the outside of the ear, or just inside the ear canal there, that can be caused by an obstruction in the middle ear, like serous otitis media. That is fluid in the middle ear. I didn't have anything about that. And then acute otitis media. Acute otitis media is the fancy term for ear infection. They can have perforated tympanic membrane. That's a perforated eardrum or a hole in their eardrum. And then otosclerosis. Hearing is frequently restored by removing that obstruction or treating the disorder. So if they have a hole in their eardrum, there's a surgery that can fix that. If there's a growth or a polyp, if there's impacted cerumen, that can be removed. Sensory neurohearing loss is damage to the inner ear or even the auditory nerve. So that results in a problem with the perception of sound waves. So sound is conducted normally through the outer and middle ear structures. And if there's a problem with the perception of sound waves, that's what results in the hearing deficit. So just another way to explain that. Causes, there's hereditary, so things that are passed down. Degenerative changes as we age. Intense noise exposure. Ototoxicity is from medications. There are some medications that can cause hearing loss, and then some diseases. Measles and mumps are a couple of diseases that can cause hearing loss, and the other one is meningitis. Mixed hearing loss, so maybe you have a combination of both conductive and sensory neurohearing loss. So for hearing tests, this is a tuning fork that you see here on the screen. It's important that you use that tuning fork. You test one ear at a time, and the ear not being tested should be blocked by an earplug or a mask. So the different types are a gross screening test, tuning fork test, and then audiometry. The gross screening test is very simple and quick. It's used to identify a very large hearing impairment, and it's done by performing what's called a whisper test. So you stand 1 to 2 feet away from the patient and you whisper some simple word or series of numbers, and then you ask the patient to tell you what you whispered to them. If the hearing loss is detected, then often they'll go to a more specific test. The tuning fork test. When the tuning fork test, those frequencies that are emitted by the tuning fork are the same frequencies that fall within the normal range of speech. And it's the Weber and Rhine test, so we're going to talk about that. So the Weber, this is useful when one ear hears better than the other, and this is commonly going to be performed by the provider unless you are in a specific, maybe audiology office or ear, nose, and throat doctor. Those specific areas you might do this. So you set the tuning fork into vibration. So what you do is you see where the gentleman is holding onto the tuning fork. You would take the top part of that, you would hit it against your hand, it makes it vibrate, and then you put the base of the fork in the center of the patient's head. And then the patient tells you where they can best hear that sound. So normal hearing, the patient hears the sound equally in both ears when you administer this test. If it's conductive, they hear the sound better in the ear that's causing the problem. If it's sensory neuro, the patient doesn't hear sound as well in the problem ear. So it's kind of backwards for that. The Rhine test, that compares the duration of sound perception by air conduction with that of bone conduction. So this is where the bone comes in. So again, you would set the fork into vibration. You would hit the end of it on the base of your hand, and then the fork is placed against the bone of the mastoid process. And then the patient indicates when the sound is no longer heard. So that mastoid process is behind the ear, if you remember that. And you would, that's where the base of the tuning fork is placed, and then the patient indicates when they can't hear the sound. But the prongs of the vibrating fork are placed in the air. It's 1 inch from the opening of the ear, and then the patient indicates when the sound is no longer heard. So with the results of this test, the normal hearing, the patient hears the sound twice as long through air conduction as through bone. And with conduction, the patient hears the sound longer by bone conduction than by air. And in sensory neuro, sound is reduced. So the patient also hears the sound longer through the air than bone, but not twice as long. So that's kind of confusing. I think it's just important to know that you can use a tuning fork to test a patient's hearing. I don't know that you specifically need to know the results of those. Audiometry, that's a measurement of hearing acuity when you use an audiometer. It's an instrument that qualitatively measures the frequencies of sound waves. So it provides information on the how extensive the hearing loss is and which frequencies are involved. So usually this is in a quiet room. Sometimes patients are in a booth. They put headphones on snugly over their ears, and they assess each ear separately. So there's a single frequency that they hear in their ears one at a time, and then the patient signals when the sound is heard, and then the results are plotted on a graph. So the patient usually raises their hand on which ear they hear the sound in. You maybe remember doing that as a child or have that done yourself. Tympanometry. So this helps determine the cause of hearing loss and is used to diagnose serous otitis media. Remember, that's where the fluid is in the middle ear. It's not a hearing test. It's an earpiece that's attached to an electronic device. So in a normal ear, the eardrum exhibits mobility and will respond to pressure. But if there's fluid present in the middle ear, the eardrum won't move. And then the results are printed on a readout. So if we talk about irrigation of the ear, it's where we wash the auditory canal with a flowing solution. So we might do that to cleanse the inner ear to remove earwax or discharge, or to relieve any kind of inflammation. Maybe they're applying an antiseptic solution, or applying heat to the ear. So you don't want to perform irrigation if the tympanic membrane is perforated. So usually the physician will tell you to wash the ear first. Sometimes with impacted cerumen or a lot of earwax, it might be softened first if there's a mineral oil or hydrogen peroxide. There's also Debrox. That's an over-the-counter ear oil that you can get that will help soften the earwax. And what you would want to do, you would pull the ear again upward and backward, and when you are irrigating, you wouldn't want to you would use a syringe. Oh, there's some certain ear syringes, and then other times, some people take a large syringe and they use like a very small catheter that goes over a needle, like if you're putting in an IV, and they cut that. And they'll put like tap water and hydrogen peroxide in a container. They'll draw it up into the syringe. They point the catheter towards the roof or towards the back side of the ear canal, and then they flush the ear with whatever they're going to flush it with to help remove either that foreign body or earwax. So installation, instead of irrigation, we're going to instill drops, so liquid into the external auditory canal, and we're going to do that to soften impacted cerumen. We might combat infection, so we're giving antibiotic ear drops, or maybe a drop that will help ease pain. Usually they're dispensed in a plastic container. We've probably already all seen them with kids. They're in a little dropper, just like eye drops come in, or sometimes they're in they have a little dropper. Sometimes a moistened cotton wick can be used, or a cotton swab, but usually when you're putting those eardrops in, it's that little container, and it's either got a little dropper, or you can just squeeze the container and drop the ear in, or drop the drop into the ear. That's the end of the discussion. Thank you for listening.